Joining us for this next panel discussion, and it bridges very nicely from the women's health focus that we had in our previous panel. Now we're going to be looking at exploring new frontiers, bridging IVF and genomics. Joining me on stage, because I have the wonderful chance to moderate this particular session, may I please introduce and encourage my guests to sit under their names when they appear. Dr. Azar Attia, who's the clinical geneticist and head of clinical genomics at M42. Big round of applause for Dr. Azar. A friend of the stage with us here, Dr. Monica Chawla, consultant reproductive endocrinology and infertility at Health Plus Fertility. She's come from a very busy schedule to join us. And Jules McDonald, the Director of Clinical Operations at Health Plus Fertility, another friend of our stage. Thank you so much. Ladies, please do take your seats. Now, this is cutting edge material that we're talking about here. Jules, I'm going to give you the helicopter question. Let's take a helicopter view on this topic. Imagine we're on a plane flying over the inaugural Abu Dhabi Global Healthcare Committee, and we've focused on this particular session. It's all about bridging IVF and genomics. But where are we on that journey? Bring us to speed if we had to take that very kind of overview.
I want to bring you to where we're at now, but I also want to take you back. And let's just think.
Bring the mic all. Sorry.
It's 2024. 20-something years ago, we were talking about savior siblings. We were doing testing to create children to help other children. We have come so far. The genome program is just incredible, and what we're being able to do for patients and this testing, 600,000 people already have been tested. There's so much more we can do. There's so much more we can find out from this, but to be able to help the patients of the UAE, less IVF tries, less children born with disabilities. There's so much help that can be done. We haven't really scratched the surface yet, if I believe, in terms of how far this can go. There's so much we can do, and it's something that we are working on with Health Plus continually with G42 in terms of the patients and the way we're sending them for testing, making sure that we're encouraging people to do this test to ensure that we are giving them the best care and being able to specifically look at the exact problem and make sure we're creating embryos that are only going in a patient that are going to be giving them the best outcome in the end.
So a celebratory note that we've come far, but there's a lot of work still to be done. And as you say there, you underlined the point that it's a case of ensuring there's health of the embryo and health of the mother going forward. Are you optimistic at this very point before we look at the future?
Extremely, and to have Dr. Azza, Dr. Monica, Tiago, there's certain people that we're working with in this organization that are so exciting, and the meetings we're having and the advancements that's coming on top of this and the information that we can get from this and what we can do with it is extremely exciting. And I'm sure in the next 5 to 10 years, it will be incredible of what we can actually do and where we will be.
The key word you used there was advancements. Let's unpack that. Dr. Azar, if I may bring you in on this point. The advancements in genomics testing technologies in this particular area, when we talk about reproductive health, it's very exciting. But when we talk about genomic technologies, what do we mean by that? So unpack that before we talk about the advancements themselves.
I'll give you just an example. I started genetic in 1998.
Wow.
And by that time, we were only able to do what we call karyotype, which is a chromosomal analysis. By that time, we were able only to do few tests, which were called PCR, where we detected only very few genes in this PCR analysis, and sometimes it wasn't conclusive analysis.
And where was this, where you started your journey in 98? Where were we talking in the world?
I was in France. So by that time, I get to use to get prescription from doctor, general practitioner, asking me about genome analysis. So I was looking to my colleague by that time and laughing. What does he mean by genome analysis? He wanted to say karyotype because it was the only test. But I wouldn't expect that just in 20 years, I'll be able to do the genome analysis. I couldn't even imagine that. So that's what happened in the last 2 decades. NGS technology, next generation sequencing, which is able to analyze 100,000. We are analyzing in only one analysis 20,000 genes.
That's extraordinary.
Yeah, 3 billion bases we are able to analyze in a single run. So it's a huge advance in genetics, which we wouldn't expect 20 years ago. So this is a capacity nowadays to do this analysis and to check what gene is affected, if the child will be affected or not, if the parents are carrier or not. All these kind of analysis were not available 20 years ago. So this is a big advance, in my opinion. And also to cross-check all over the genome, it's huge advance in such short time.
Now, you explained there the need for this type of testing because you want to check if the parents are affected.
Exactly.
So that's really imperative. So if I can bring in Dr. Monica at this point, what factors indicate the need for genetic testing before or during IVF pregnancy from a clinical point of view?
Good evening, everyone. So at the outset, let me start by saying that clinical genomics is going to really revolutionize the way our contemporary practice is right now. And there's a huge paradigm shift already in the way we are seeing our patients, and it's going to just carry over. The algorithm of when a patient comes to us obviously starts from the history point of view, talking about endocrinological investigations, imaging, ultrasound evaluation, and we used to do some basic tests, we used to do karyotypes and all, but with the advent of clinical genomics is going to change. I believe that I can imagine that at one point of time, maybe patients, apart from their marriage certificate, they're also going to bring their genomic passports with them.
That's so exciting.
So that's going to happen.
Dr. Monica, please keep the mic up because you're making such important points. I want to make sure we capture them. So that's an interesting vision that you have.
So definitely it's going to strengthen the physician's approach to the patient, bringing in more personalized diagnostic and therapeutic strategies. So let's look at the kind of categories of patients that we get and how they're going to benefit. So first category is the patient who walks in with a problem, say menstrual problems, amenorrheas, ovulatory dysfunctions. When we actually do targeted genetic testing in some of them, you would actually find mutations like FMR mutations. And by just chance testing, you could be detecting patients who are going to lose their ovarian reserve in a very short course of time. So they are the patients who would actually have a premature ovarian failure in a few years. But right now, you're going to detect them maybe 10 years before, and you're going to act on it. Complex multifactorial diseases like endometriosis, polycystic ovarian disease, which used to be, we knew that they have a genetic predisposition, but right now we're in a position to bring them to a conclusive causal diagnosis with gene alterations. So when you have a diagnosis, it's important to approach a patient, it's important to face these challenges. Coming to, so overall, 50% of infertility patients could have a genetic basis. Men with oligospermias, asthenozoospermias, azoospermias, we are detecting cystic fibrosis, Klinefelter syndrome, and 20% of these patients would have a genetic basis. So this category of patients is extremely important. Coming to the preconception screening that we are doing right now, so that is virtually targeted to everyone. Every patient who walks into a fertility clinic is undergoing a whole genome sequencing, a whole exome sequencing. So what are we discovering with this? We are detecting high-risk couples who would have a chance of having children with birth defects, learning disabilities, metabolic disorders. So you're actually giving them, you're predicting some of the outcomes for them. And so they would be eventually, obviously it needs a lot of rigorous counseling when it's chance detection. And after a lot of counseling, they would probably be directed towards pre-implantation genetic testing. Also, when you discover these patients having single gene disorders or recessive disorders, a lot of them are having reduced reproductive potential, which is again detected well in time by this technology, and we are directing them to the more efficacious forms of treatment. The third category is patients actually who are doing IVF for various reproductive reasons. So when they do IVF, obviously clinical genomics is going to optimize the success of this IVF. We are obviously doing pre-implantation genetics for long. The first baby of PGD was born in 1989. That was cystic fibrosis. And now we've come to a level where we are detecting based on screening. So one is it is going to optimize the success of IVF because we are selecting the best embryo not only on the basis of its quality and its morphology, but also on the basis of its genomics. So what happens is the time taken to get pregnant is reduced. A number of wasteful cycles are reduced. And of course, the single gene disorders are getting detected. So we have definitely the nation's burden on the health resources for birth defects, metabolic disorders. The emotional burden on the parents would definitely get reduced in the future. So with all this, I hope that we are getting closer to our goal of a healthy live birth, and also increased success of IVF would help us to transfer more and more single embryos. We don't need to transfer 2 or 3 embryos as used to happen in the past to get a pregnancy. We could transfer the best, genomically tested, and with addition of artificial intelligence to it, it's going to go even further. So we would have lesser failed cycles, we would have lesser cancelled cycles, we would have lesser wasteful cycles, less financial burden, less emotional burden, less psychological burden on the couple. So a healthy live birth, less pregnancy losses, getting answers to a lot of unanswered questions. And that is helping hugely in patient counseling and getting the couple together in an informed decision making.
Thank you so much, Dr. Monica, for that very comprehensive answer. And as you outlined, there's those 3 major categories. And the imperative is absolute. We know that this is an area that really does need the funding and the attention. So to have this clarified for us is really important. Many of the subjects we talk about here, often there's a case of making a case of why should we even be investing in these areas. But this particular area, I think it's clear. Jules, I know you wanted to jump in.
I just wanted to say I don't think a lot of people understand how difficult it is to get one normal embryo. Women who have premature ovarian failure, who could be young, have to go through multiple cycles to get even 1, 2, 3 eggs, to then take that to a day 5 embryo, to then biopsy it, to then test it, and hope you get one normal embryo. That is extremely difficult. So the earlier we find out this information, the earlier we can test. This is very important because the stress on any woman to go through multiple cycles it's awful. And I think a lot of people, the psychological effect on that. So women are aging. Longevity is, the key of what we're discussing as well here. And with stem cells and future advancements, there will be a chance that women at a later age will eventually be able to grow an egg. We're not there yet, but this is something that we need to think of in the future. Yes, we are using AI and different technologies as well. As an organization, we are really moving forward with every way on a tech level that we can ensure that our patients get the best level of care.
And so when we talk about this, and there's a real hope, there's a real need for this, we're not simply talking about only the testing side. This is also about the efficiency as well. This is about allowing more successful pregnancies.
And avoiding miscarriage as well. Unfortunately, it's normal in other countries in the world to experience 3 miscarriages before anyone sees it as a problem. It's a huge problem after the first time, and we need to be ensuring that women are having the chance of having a successful first go and not having to go through that.
Absolutely. So the case for this is a no-brainer. Dr. Azar, what are some of the limitations when we talk about genetic testing?
So, of course, genetic testing, it depends on the information that you are giving to the clinical geneticist or the lab to do the analysis. So if you don't give proper information to the person who is doing the test, he will not be able to help you, especially that we don't see the patient. It's a physician who sees the patient in first line. So I'll give you just an example of a story which happened effectively in life with me. I've seen a patient who was so young and who married the first lady, and he had a child with trisomy 21. Then he get married to a second lady, and again he get a child with his trisomy 21. So it was so difficult to him to admit that he is getting only children with trisomy 21.
So what do we mean by that, so we understand this, that the
Down syndrome. So he get 2 children with Down syndrome from 2 different women. And when we did the genetic test for him, we didn't find in his karyotype, in his chromosomal analysis, he was normal. Although the problem was where it was in his sperms, not in his blood. So this is one of the limitations of the genetic test in pre-IVF, that we are not able to detect the anomaly in the sperms or in the eggs. We are able to detect the anomalies which are in the blood of the person, but the germline mutations, we are not able. So this can create a de novo mutation, what we call de novo mutation in the fetus. And we are not able to detect this. And this needs to be explained to the couple during the preconception testing, because we need to set up the expectation of the couple. We cannot go beyond the de novo mutation and detect them. Also, we have the expression analysis. We can detect the gene can be there, but it's not expressed. So we are lacking this part, but it is coming in the pipeline by doing methylation analysis of the genome. So these kind of limitations need to be explained very carefully to the couple to understand what are our limitations in genetic testing, and of course give us as much as possible of information. It's not enough to tell me that this person is suffering from infertility. I would like to know which kind of infertility. Is it polycystic ovary? Is it primary amenorrhea? Is it secondary amenorrhea? Which kind of problem is this couple having?
Thank you for making this really accessible to us. I know in our pre-briefing I was urging that there's a lot of technical references, there's a lot of terminology, and we want to ensure that everybody is on the same page. So I do appreciate you making this as accessible to us here. Very complex science behind this.
Yeah.
And you use the word expectations. I'm going to come to Dr. Monica. Earlier you mentioned that the role of counseling as part of this process as well. So allow me to just get an insight in terms of, on average, when patients come to you and you see them, how much knowledge do they have of this area? Is there a lot of taboos and myths that you have to dispel, as well as actually bringing them up to speed with the technology?
Well, the couples, I've been in this practice in this country for quite long now, 1.5 decades, and I've seen changing perspectives. The knowledge level, the education level has come a long way. And of course, patients would have, if they have children with birth defects, they would have possibly undergone genetic testing, and they have some idea about these disorders. They know that they have a defective gene. But there are a lot of couples who are getting more and more aware, but they're welcoming the knowledge. They're welcoming the knowledge, and we have to do these tests for couples together. So because of this genetic testing, that's an opportunity to bring them together, to talk to them about the need for genetic testing, and also because we have a lot of consanguinity still in the UAE population, it becomes all the more important that they understand it. But the good thing is that their perspectives are changing. More and more couples are coming together. They are willing to understand the reason for testing, the reason for why the government is pushing for avoiding birth defects. We need more. We don't need learning disabilities. We don't need metabolic disorders, how it emotionally affects the parent for their whole life, how it financially affects the resources of the country. So they're willing to understand that. And that's a very, very welcome change, actually. And I've seen it in the last 7 to 8 years, and more so in the last 3-4 years, that they have become aware of the genetic testing aspect of it. And they are very welcome to doing it. They are welcoming more knowledge. They are willing to go for counseling. And they have a lot of questions which need answers, but they are very, very receptive to this kind of, clinical genomic change that the country is seeing.
Thank you so much for sharing that fascinating insight. It's really good for us to hear what's happening on the front line and to hear about that interaction. You say there's lots of questions to be answered, and I'm sure our audience have probably got some questions as well. So I'm going to open it up. Please don't be shy. Shoot your hand up, we'll get a mic to you. Anyone got any questions? Or we can come back to you, because I've got a few more. The gentleman here. We like to make sure that we're representative, and so please do. Introduce yourself and who your question is for.
Hi everyone, thank you for the great presentation. I'm Mohammed Asman. We're here working in Abu Dhabi as a product manager, handling some IVF products like that. So one of my questions is for Dr. Monica and Dr. Jules. I wanted to ask, I know that you're saying miscarriage is a major issue that happens in all cycles. But the issue that I'm seeing with it is because there's no way to check for balanced losses or gains, right? So how is your plan to overcome that? And if you do with linkage analysis, other more advanced features, what happens to your price? Is it possible to balance both of those aspects?
Okay, interesting question. Is that something that you ladies want to tackle?
So you're talking about the price, the pricing.
Into your, say you incorporate linkage analysis using SNPs in your workflow. It's very practical and it has major advantages, but then how do you balance that with allowing it access to all patients? So it's more of a question of access of different economies.
Yes, very good question. Obviously, as you just said, the structural rearrangements of chromosomes are one of the major reasons for these miscarriages. Now, at the moment, it is freely available to all the Emiratis. So we are not facing any issues there. It's available and they undergo the testing, linkage analysis, followed by pre-implantation genetic testing. For the rest of the population, the expatriates especially, well, yeah, they are being given, various kinds of promotional prices, discounts, as much as possible. We're trying to include it in the program, but at the moment, obviously, they have to pay for it. But the center and we are with Mubadala now, they're constantly working on prices so that it becomes affordable and accessible to all without any bias. And we would want everybody to be included, everybody to be benefited from this particular service, since reproductive genetics is big right now, and we are doing it day in and day out. We have absolutely brilliant skills in the lab. So this country especially, I think the amount of genetics that we do here is incomparable to anywhere else in the world. So we would like everyone to benefit. Of course, we have overseas patients also coming in for it. So the pricing part is not my job, but I'm sure I have to direct these patients to the right department, and they're constantly working in it and taking care to include everyone possible as much as possible.
Thank you for tackling that question, and thank you for that question. We have run out of time, but I'm going to give my panelists a chance to provide a call to action. I have invited my speakers throughout the day to end on a note of what would you like to see in the near future? We have powerful people in the room, powerful people watching and listening in as well. And we have very interested members of our community. What would be a call to action, if I may start with you, Jules?
My main focus right now is precision medication and being able to use the information we have from patients to really hone down with the exact amount of medication they should be taking for each cycle based on them, because a lot of doctors still, use what they were taught many years ago. Certain amount of hormone should be given with a certain amount of drug. Things change, but I do think precision medication is where we need to be going forward to.
Fantastic. Dr. Monica?
So, yeah, I mean, in today's era of precision medicine, it would be great disservice to our patient if we provide them one size fitting all. That's absolutely not an optimized service. So the idea is that to incorporate their biological, environmental, genetic, their lifestyle, their patient preferences, their previous responses into the whole profile, and then they be treated according to that unique profile. And adding on to this, of course, we talked about pre-implantation genetic diagnosis going forward. Artificial intelligence plus genomics can be totally a next level, it can be huge benefit for these patients. And this is what we're looking at. So we're looking at personalized IVF, totally unique to the profile of each patient. We're already using a lot of it in our current IVF practice by selecting sperm, by egg scorings, where we're giving each egg a score to know whether this would become a good blastocyst or good embryo in the end, which would give us pregnancy. We're grading embryos based on artificial intelligence, and then also selecting a particular day when the embryo should go back into a woman's body.
Fantastic.
So even that is very specific.
Brilliant. So we've heard about precision medicine, and we've talked about that personalized IVF treatment. Dr. Azhar, final word with you, and of course with your M42 perspective as well.
So one of our main perspective is awareness among physicians before awareness among the general population. Raise awareness is very important, and also removing the stigma which is put on the female, because we are also testing for X-linked condition which is related to female. So I hope with time and with progress of this program, these 2 points will be solved.
Absolutely. And your point astutely underlines what our panelists have already spoken about, because awareness and dispelling myths and tackling taboos is actually what the whole game is about. It's what an event like this is about and what sessions like this are about. So I really appreciate you all taking time out of your very busy schedules to join us and be here and share your insights and your wisdom. Ladies and gentlemen, please give them a big round of applause. Now let's take a lovely photograph with my colorful panelists. Everybody, it's almost like we had a brief to ensure. Fantastic. Fantastic. We're back in 2 minutes. Thank you very much. Thank you.
Thank you so much.
You're always so good, Dr.